Hi everybody, this is Erica Mello and welcome to episode number 110 of Tough to Treat. We all hope you had a wonderful Thanksgiving, and this is a continuation of a patient that we discussed in episode 109. So if you haven't listened to the podcast episode prior to this, I would suggest you do so. It may make it a little bit more seamless and easy to understand when you actually do listen to this. And if you have listened to part one, what do you think the driver is and how do you think you would progress exercise? That is what we really focus on in this particular episode, because you're not going to treat 5 regions of the body. You're not going to, that's really not efficient, right? So in my clinical experience, you're looking at maybe 2 regions, at just primary regions to treat, and you design an exercise or movement program around that. You don't design, or I wouldn't say don't, it's not wise or efficient to design a program around their symptomatic region if that's not their driver, right? So if the foot is driving somebody's knee pain, you're going to design an exercise program around the foot versus the knee, right? So this particular episode talks about how I worked with this patient in developing a movement program for his 2 driving regions. And it is going from unloaded to loaded and neutral to non-neutral. So think about that and those principles as you're listening to the episode, as well as you're working with your own patients. And I know Susan and I have talked a lot about our podcast membership. It will be coming probably in the next week or 2, so look for that. And it's going to be an amazing club membership. We were going to have a couple, 2 more episodes, and one will be an Ask Us Anything, and we're going to have some really great interviews with really master clinicians that are flying under the radar, treating tough to treat patients. And I want to thank everybody who signed up for my Decoding the Complex Patient course. It just finished, and appreciate all of the people who signed up and really enjoyed doing this. I'll probably launch that again sometime in the first quarter of 2022. Enjoy.
Hey everybody, this is Erica Mello and Susan Clinton. Welcome to podcast episode number 110. This is, how are you, Susan?
I'm good. I'm good. Ready to jump into part 2. Let's make it happen.
So if you have not listened to part 1, I would highly advise you to do so. You will learn something by listening to them separately, obviously, but part 2 before part 1. But this is a really interesting patient, and it would behoove the listener to listen to part 1. So, okay, so following up. So I determined in my prior evaluation, this guy, just for people who listened to it a while ago, right foot issue, right hip issue, sternal, AP sternal issues, and bilateral anterior posterior neck pain. Priorities for him were foot and hip in terms of meaning. Everything else sort of just came on later, but in full disclosure, that's what he wanted. He sort of mentioned it. So I determined based on my evaluation that the foot and the hip were drivers, both drivers, that they were both regions of the body that when treated separately, that's an important distinction, that when treated separately made him worse. And separately, I mean in the same treatment session or the same session, because he would remark at home how he worked on his foot, made it foot better. Obviously, it's going to make the foot better. You're working on it, right? But it made the hip worse and vice versa. So that's sort of what we discussed in part 1. So as of part 1, I left everybody off with, he did all 4s, both of his feet in plantar flexion, going back and forth with neutral spine, and seated heel slides and heels. So seated, sitting with his hip corrected, and doing seated sort of right heel slides into plantar flexion, dorsiflexion, right? Knee extension, plantar flexion, knee flexion, dorsiflexion, right? With some imagery and cueing to soften the foot. Okay, that's what I sent him home with. He came back and he's like, oh, and he had an issue with knee extension, right? In wall squats on the wall. So just once again, go back to the part 1 if this is not ringing a bell for you. I did want to mention that when I saw him the second visit, I wanted to check his slump test. No reason. I just wanted to see where he was in terms of full length, like where he, in a seated position. I wanted to just see what lengthening his whole dural system did for him. So I checked him the way you do the slump test, and you could see all his compensations. And he was like, oh, it feels weird in the hip. And so what I did was at the time, I did not have the mechanical high-low table. And so I put like a foam block that you see in a lot of the Pilates studios. I had him put his feet on the block. I corrected, modified his right foot as I discussed in part 1, and I put it on the block.
Okay.
Had him just pick his left foot up to put it down, and then I checked his slump. And it was significantly better. So once again, the foot's not dangling. I corrected it, modified it, put it in a closed chain, on the block, and slumped. He's like, oh, that feels great. I can posteriorly tilt my pelvis now. When I took the foot off the block, he just couldn't posteriorly. He was this, he was shifting, he was doing everything going, right? So I did want to mention that because that was something I did for the first day 2, the first thing, because I had forgotten to do that in the eval, which I wanted to. It wasn't a priority, but my time was obviously running out with him.
Trying to tease out if this is a neural tension dural problem. And that may be why he's like being pulled over to the right all the time.
Right. So the foot correcting the foot made his flutter significantly better, and it was in his awareness. So I just did that, noted in my brain. And so going back to part 1, I did assess the foot, did assess the hip. We always talk about what's the impairment, right? Is it an overactive system? Is it an overactive muscular system? Is it an underactive system? And I will venture to say with this guy, he definitely had issues with control, right? Was that because it was like he had strength pulls or was underactive and he had an overactive system keeping him there? Sometimes when you release muscles or you get people moving and their muscles soften, they can move well. Not the case with him, right? I do believe, and I don't want to go into the hands-on treatment because I want to talk about the exercise. That's the most important piece with him. I did do some, if anybody has questions, they can contact me, but I did some release to the foot, gastroc, posterior tib. I didn't do anything to the hip in terms of release, maybe a psoas release, but I actually didn't do any hands-on with the hip. Okay. In terms of like soft tissue work, I did do it in the foot. So I'm going to go through that. So his impairment, I believe his overarching impairment was maybe a little bit of an overactive superficial system, but I believe it was mostly an underactive system that was driving his issues. And it wasn't, and I do believe that he did have some strength holes and also just lack of control. So a control program is different than a strengthening program, right? Strengthening protocols are different. So it's important that the listeners understand that the impairment, you have to distinguish that because you will need to be able, because your exercises are going to be different. So what I did with him, after I sort of rechecked everything, I put him, and this is really where it gets interesting. I got him back into all fours. So I did the release work. I held his foot. I put his right foot into dorsiflexion and his left foot into dorsiflexion. And I just had him go back and forth. And he had a hard time going back and forth, back and forth. So we talk about, training. If you're just giving input at the foot, whatever it is for you as a therapist, whatever you want to do, I once again, just gave him in a better position. I gave him a little bit more dorsiflexion. After I worked on his foot manually, he did have that. So he was able to do the all fours a lot better. So I did a lot. I wanted him to do a lot of repetition with good control because that's going to train the brain into a better, I don't want to say better, but more optimal movement pattern for him. So yeah, it was easy for him, but his brain is like, oh, I can actually dorsiflex. I can get off my right side and I can have options for movement. So I had him do that like 30 times. Right? What is it? You need to do something at least 50 times. Somebody did some work on that years ago, like how many reps and sets. You need to do a lot of it. You need to do volume to train the brain, right? Especially for somebody like that who has such ingrained movement patterns. So I did a lot of that with him the first visit, release, and then I also did the half hands and knees. So I then wanted, because his hip and his, so generally the hip and the foot, they made each other worse. There was a point, and it did come to this, where I got him into a better position where they actually ended up making each other better. So I did feel the need to work on both in the same session. So when you have two regions of the body that are not doing great things for each other, you can't just like, I couldn't have just released the foot and then said, see ya. You would have been worse, right? So you have to understand that before you start your treatment session, however much time you have as a therapist, this is what, if I want to do one thing, you do. With him, I had to be both. So because he didn't need a lot of release hands-on work in the hip, I was able to get that with putting my hands on his hip, right? That tactile cueing, and that's actually treatment for the hip. So I was able to get him to center his femoral head with just manual cueing, not so much digging my fingers into his psoas and iliacus, right? So I, in a sense, getting him into hands and knees after treating his foot and putting my hands on the hip and going him into 40, 50 reps of all fours, that was treating both drivers in the same session. Okay, so I progressed him. So in terms of exercise, since both areas were drivers, I can't just give him heel raises and have him go home, right? So what I ended up doing is I had him in standing, because squats were okay for him. I had him go into standing, and this is after working on the foot, go into a deep squat, because he was pretty okay at that point, and then he went side to side. I said, just go side to side. So you know what he did? So it was his right leg didn't want to go into that knee extension. So I had him go, when he went to the right, he was okay because his knee was still bent, right? And his left leg wasn't getting straighter. It's almost like a lateral lunge, but you're really not actually lunging. You're just doing a deep squat. You're going side to side. When he went to his left, that knee was starting to do the funky thing, how it didn't want to straighten out. So I stopped right there, and I had him just do that in a very limited range of motion.
Right.
His knee got the mobility. Right. So then bear in mind, you know, I mean, this guy is by all time not an easy person to treat in terms of his issues. But I actually loved working with him because he was so motivated. And so I had him go on the wall again. Okay, so for those of you who listened to part one, had him on the wall, and he could not straighten his knee out when he came up from a squat. He did a wall squat with his hands on the wall, could not straighten his knee out. I put his heels on a half foam roller. Okay. And I just said, just do a little bit of a squat and come up off the foam roller with your hands on the wall. And then my hands were at his hip trying to guide him. He did that, did it a bit better, was able to straighten his knee out a bit better. So I did like 20 of those. Okay. And I'm moving along with this guy. I normally, I don't tend to sort of, because I believe, this is my belief after seeing him now for so long, that I believe that his nervous system was so sensitized in a good way, but he picked up things very quickly. So you know how you have people, you do a little bit of hands-on work and they're like, great, they feel amazing, like they're good to go in terms of like their movement patterns. He was that person. Less is more with this guy. This was the less is more type, okay? So I had him on the half foam roller going from squat to stand, squat to stand, squat to stand. Took the foam roller away, did that like 30 reps. Had him try it again on the ground, and he still had a hard time. So what I did was I said, look, you need to kick your hamstring in, because as far as I know from my PT school days, is that in closed chain, the hamstring extends the knee. That's what I learned. So when he went into a squat, he came back up. I was tapping. Remember the tapping that we talked about so many times? I was tapping his hamstring, and I was like, you know, this is what you need to do. You need to kick your hamstring in. You need to kick your hamstring and straighten your knee out. And he was getting it when I was doing that tapping. So I'm going to stop there, Susan, and let me know what you think.
So no, I think it's interesting. The hamstring can be a knee extender, and in closed chain for sure. And he was overworking his gastrocs to be the knee extender.
Yep.
Because, you know, the gastroc tightness and the foot inversion. And so the medial heel coming up while he's trying to straighten his leg, it's his gastroc trying to do it. And, you know, guys actually, you can use hip rotators as well. And that may be why every time he did something with his foot, his hip couldn't cope, because the rotators weren't working to help, bring the leg into a better position, and so the hamstrings were probably a key there for him, to help him be able to just bring more players, bring more instruments into the symphony, because only one thing was working, and that was pulling him off every time. And then, he just wasn't able to do it. So is his hamstrings tight? Were they like over recruiting and that's why they weren't working, or were they just under recruiting and being inhibited?
I think they were under recruiting. I think his main impairment was just lack of motor control. Yes, maybe a little bit tight, but I wouldn't say, if I had to pick one, I would, it was not like tight. He was not a tight. He had like muscles that were gripping, specifically like gastroc, posterior tib, anterior tib. But
the reason I was asking is because of that posterior rotation of the pelvis that he kept trying to get himself out of. That can be lower glutes, it can be coccygeus, it can be obturator internus, but it can also be the upper hamstring. So maybe the upper hamstring was inhibiting the other part of the hamstring. It's hard to say. The idea is it just wasn't timing really well. And, the gastrocs were really trying to do the work. And I think that that's pretty important there, for him to be able to have the hip and the foot do things differently together, rather than, kind of just following the same movement pattern that he's been following for a long time.
Right. And so for our longtime listeners, or listeners who know what we talk about when we say resets, for him, his reset was a bilateral movement. It was just going into a squat. That that was his just squatting, and then obviously when he came up, he couldn't go into that knee extension, but I just had him do a squat, come up halfway, do a squat, come up halfway, do a squat, come up halfway. That was his reset from the get-go. Okay, a bilateral movement, because I remember a reset's an exercise the person can do well, right? She could do that well, part way, right? So that's what I gave I forgot to mention that in the last in part one. So that was generally his reset. So I do agree with you on that hamstring. I mean, so what I ended up also doing with him on that visit, I had a gut feel about something. So I got him on I got him on the Cadillac, but I had a box, and I just had him go into the supine tabletop position. And I just had him do some dorsiflexion with knee extension in the tabletop position on the Pilates equipment, just because it was easy. And, really trying the imagery, the cueing with the foot. And he did that. And I gave him, that was in addition to his home program, just straight sliders, whatever you want to call them. I said, you can plantar flex your foot, you can straighten your knee out, you can make this up, just change the input at the knee and the foot. And he got that. So he actually did that. I'm going to just fast forward a little bit, because he was still doing the all fours. I had given him the hip side to side to do, actually in very small ranges of motion. Any range of motion that caused him to straighten his knee out, I shied away from right now, because the foot and the hip were still making each other worse. I assessed that every morning, every time I saw him. And so then I added, I had a feeling that there may have been like a neural tension piece in the lower extremity, and so I gave him that tabletop. And he comes back like the next visit, he's like, oh, I can posteriorly tilt the pelvis now. And I'm like, of course you can, and so once again, I'm just going to move forward here. So bearing in mind his foot, his hip, or his drivers, I believe he did have a lower quarter neural tension inhibition, or whatever you want to call that, right? So he was still doing his heel slides, his just sliders, and his I gave him the hip side to side, and his squat was his reset. I'm gonna move on here. Okay, so at I would say few visits later, because I want to get to where he is now, this current exercise piece, which is really interesting. I remember that one-legged standing is really hard for a hip to do. Okay, so I started him bilateral. Then I also just we started doing split squats. Okay, so the inversion eversion piece of his foot, he was okay with. that really wasn't where I thought the impairment was. He could invert and evert okay. Wasn't great, but that was not what I focused on at the beginning, okay, because that's also really hard for me. So I got him into a split squat. It was his right foot. I put his right foot behind him and his left foot in front. Okay, so that right hip is in extension, that right foot is in that sort of rigid lever, and I had him squat down. And I assessed that at the beginning of the following sessions. And Susan, when I tell you, when he came up into knee extension on that back leg, he was like, I was like, oh my God, stop. His knee was in such a torque. I was like, you go, no. Because he would actually injure his knee, right? And I'm not joking. I was like, you can't do that. You can't do that. And you know, his knee was not symptomatic because he compensated so well.
Right.
But when that foot was back in full knee extension, hip extension, in full plantar flexion, he didn't have symptoms, but he squatted down, Susan, to get into that dorsiflexion, and his knee was like in such a valgus. I was like, I stopped him. I stopped him midstream because I've never seen a knee torque like that before. So clearly, there's something that's just not moving well still down in that part of his leg. So I'm going to move on because I did progress some of his. So I did not give that. That was more of a barometer. So I'm like, well, we need to make that a bit better. Okay. So once again, that's the snowboarding, right? Almost, but his knees are bent in snowboarding, right? So what I ended up doing with him is I went back to the squat position. I said he needs to get the other foot on the ground in a better position. So I ended up working a lot with him and having him do side to side movements. And I blocked, what I did was I blocked his foot, and I gave him some cueing at the hip, just trying to get him to go to that left side to straighten his knee. And he was able to do that after a couple sessions. So I'm going to fast forward because this is, and I went back to the wall. Okay. I went back to the wall. I said, do a squat with your hands on the wall. And this was after many sessions of releasing his foot and working and not really touching his hip so much, but more cueing and tactile cueing and movement. And he was able to straighten his knee out a lot better. Okay. So something clicked in his brain that said, okay, I'm safe to straighten my knee out. He'd been doing the neural glides in the tabletop position. He'd been doing his reset of the squats. He'd been doing all fours still in varying degrees of dorsiflexion and full extension. I had him shift his weight side to side in all four, if you can talk about that, but I had him do that. I had him go into standing on the wall, go squatting on the wall, shy of knee extension. So I always stopped shy of knee extension. The hip side to side, I ended up doing, I also had him do, once stopping in knee extension, I had him do, we call chicken legs, where you're in a squat and then you just go internal, external rotation, bilateral. He was fine with that. So I was getting him to move his hips, and his foot was going into inversion and eversion at the same time. That was his exercise program. The rotation of the hips, that's like hard for hips. That's a rotational piece, right? And the inversion and eversion is also hard, but you're in a bilateral stance with that, right? So he was okay with that. So then I said, okay, we're going to get him on the wall, okay, in a supine position. So I had him on the wall with probably 2 pillows underneath his bum. Okay, so for listeners, supine on the table, the knees and hips are 90-90 tabletop, his feet are on the wall, his 2 pillows under the bum in hip extension. I do that to sort of take out the influence of the iliacus and psoas. And then what I did, this is after some sessions now, okay, and I'm leaving out of certain progressions because I want to get at this. This is, I thought, was really glaring, and this was recent. I said, just do some bent knee fallouts, starting there, because I knew the side to side and the inversion eversion piece was not as hard as the knee extension sort of piece, plantar flexion, dorsiflexion piece. So he did that. Oh, feel good, no problem. And so at that point, when I had reassessed him at the beginning of every session, when I did modify his foot, his hip actually was better, and vice versa. So I didn't at that point need to treat both in the same session, for those of you who have listened to part 1, okay? So I said, let's just do just a bent knee raise, right? Bent knee raise off the wall. He's like, oh, that's pretty okay. And so the table is flush against the wall, against the wall. Feet are on the wall. I said, can you do a little heel raise? Do a little heel raise. Guess what happens? He does a little heel raise. So he's in a tabletop, right? So he's pretty okay, and it's a safe position. When I tell you, he pushed the entire table away from the wall. And I give this exercise out a lot. And I go, here's what happened. I go, meanwhile, there was like literally 7 inches away from him. He literally lifted my heel up, pushed it way off the wall, It's like, yeah, you're going to use your gastroc a little bit, but you're not supposed to push that doesn't happen. That's never happened with any patient. He's the first one who did it. You want to tell me your thoughts on that before I move
That's a classic case of over recruiting.
Oh my God.
That's
Crazy.
how he straightens his knee. So he just took that motor plan is in there so strong that when he tightens up the gastroc, that's what straightens the knee. And you're taking him into plantar flexion, which is, the heel off the wall. And if he's moving into that inversion a little bit, or just that old mortar pattern kicked in, I would think that's what happened.
Yeah.
But there's certainly overriding just about any other kind of proximal control that might need to be there.
Exactly. So when I had never seen that before. I mean, I have to be honest. I give that out a lot. It's a great exercise. And so I stood at the other end of the table. I prevented him from doing that. I said, you're not going to push me. You're not going to push this because you're going to push me. He couldn't even do it. He couldn't even lift the heel up. And I said, he's like, oh my God. Well, and I was trying to explain to him the whole knee extension. At that point, he could go into knee extension pretty okay. But this was a position where I was trying to take out all of the compensations. I took out the hip flexors, and really put him in a tabletop. So yes, he was in full dorsiflexion on the wall. And then that's basically going into a squat and staying in a squat and doing a heel raise, like a soleus, right? Right. And so he did that, and he pushed on Susan. When I tell you, it was like, and he kept doing it, and he couldn't. So this is the volume. I purposely took out the compensation, stood there, said, "You're not moving, darling." This is those are the words I said. I said, "Darling, you're not moving. You're not moving the table. You're not moving the table." And so when he tried to do that, you could see the hip rotate. All the compensations are coming back. So I said, okay, straighten your leg out. Just straighten your leg out, relax your leg, shake it out. Let's train here. And so what I ended up doing, I said, I took a pillow out. I took both pillows out. And I said, come back a little bit. I straightened his knees out just a teeny. I said, can you do a bridge? Just do a bridge. Do a bridge off the wall. Just literally put your hands on the wall. I mean, your feet are on the wall in dorsiflexion. Just do a little bridge. And you want to know what happened? He pushed the table further away from the wall. That gastroc was kicking in so hard. I mean, I could not believe it. I knew the heel raise, you're going to get the gastroc in, but I wanted to see if he could do it. But this time, I mean, I took the pillows out because he couldn't get into a bridge. He was already in hip extension. So I took them out. So just do a teeny bridge, down, up, and then he's going out and out and out. He's like, oh my God, I'm pushing. He finally realized what he was doing. He's like, I'm pushing. I can't do a bridge, and I'm pushing my foot into the wall because I'm over recruiting my calf. I said, bingo. That's your issue. That's your issue. So the impairment, at this point was an overactive gastroc, right? And an under recruited hamstring and glute. That's my thoughts. What do you think?
Yeah, I would definitely agree with that.
Yeah. And
interesting motor pattern.
Yes. And I once again, that was a first for me, and this was recent. And so he's like, oh my God, how can I prevent myself from doing that at home? Because, because it's something he clearly wanted to do. Because when you're in a wall squat and you're coming up from a, squat to stand, you can cheat because you've got some movements. When you're on the table in a very fixed positioning, you can't you can't shift as much. So he just pushed and pushed and pushed through the gastroc. So I told him, I said, you can lie on the floor, put your feet up on the wall. I would start off with some pillows first, and just, practice your heel raise a little bit, because that's an easier position. And I gave him the imagery for the foot. And at this point, once again, his hip and his foot didn't make each other worse. So I was okay with just working on one region at that point. But where we were in the exercise program was very global. Okay. So he ended up, I sent him home with, we put like something, I said, I don't want you to put something that's dangerous at your head, because I don't want you pushing into it and giving yourself a head injury, So that's all I need, right? So I said, put like TheraBand or something that's soft, or a pillow or something, or have your girlfriend video you or something that that you're pushing away from wherever you're starting with. Because for him to get his bum, like, he didn't have the table as a cue, right? So it would be his whole body movement. And so I worked with him for quite some time on that in the office, and I rechecked a couple of things that I wanted to assess. And bear in mind that I did the split squats and all of that, and he had been moving a little bit through that and through very limited range of motion. So because he was so in tune with his body, I said, you got this deficit here. You need to release your gastroc. You need to release and stretch your gastroc. That's something you kind of need to do right now before you exercise. Because if you're walking and you're doing whatever you're doing, you're going to walk out of here and resort to your old movement pattern, your gastroc's going to be like, okay, I'm going to keep going and kicking and doing my thing. So you need to release that and work on that, and maybe do a reset before you do this tabletop exercise against the wall. So that's what he went home with. But I reassessed split squats in a bigger range of motion with the back foot, and it was a lot better. It was a lot better. So I believe that his inability to really straighten his knee out, he did have two drivers that made each other worse. And I do believe he had an overactive gastroc, underactive posterior chin. I believe he had a neural tension piece. That's what I believe to this day. And I'm still treating him.
Yeah.
So
no,
what do you
I think that, I totally agree. You could have him do, as
how would you progress him?
As progression, I'd get him holding onto a countertop, going into a partial squat, picking his heels up and down.
Yes.
Because he'll know if he's like shooting himself up, kind of being able to, he can sit and put his feet down and just work on lifting the heels up and down, in different levels of sitting. He can sit up taller, he can sit down lower, so he can do it with more knee extension, do it with less knee extension. I like the idea of what you're doing with him in the squat and the lunge, the split squat, because that he knows when it happens. So anything that you can do for him that when he knows it happens, I think can be quite helpful. So I think it would also be interesting to have him like put a Swiss ball underneath him.
In sitting?
And laying prone on it.
Prone on the Swiss ball. Okay.
And then he can, so his toes can be, he can be in dorsiflexion. And he can kind of come back and push and, just to see, because he'll have to like, tender that, because otherwise if he pushes too hard, he's going to like roll off the ball.
That's a good one.
So maybe, and he can be in, depending on the size of the ball or where he is on the ball, he can be in more knee flexion, and his knees closer to the floor, kind of like a modified quadruped.
Yes.
Or he can be up with the knee more in extension and, the foot in, the toes, tucked under, so that you're kind of working that way too. He's just, just again, different context might bring about different recruitment patterns.
Exactly. That's great.
Yes.
You think of, yes, and exactly. I had given him a while ago the sling squats, but I think that putting it in different contexts is good. With him, and for the listeners, I think at this point, I want to get him in positions that are going to take away his compensations, like prone on the Swiss ball. His hip is an extension, right? That's the split squat. That's the back leg, right? That's coming up from a squat into hip extension. That's where he compensates, right? Running, he actually is running fine now. I said to him, running, you'll be fine running, and he does. He runs fine. and now he wants other things he wants to be able to do, which is great. But
what about walking backwards?
I did that with him, but I will just go back to that because I can
Because he has
control
to,
that piece.
he has to grade the eccentric control.
Right.
So it's opposite, you know, it's knee flexion, then the toe down, and then eccentric control of the heel down backwards, while he has to control stepping backwards with the other leg.
Yeah, I'm just thinking on some of the Pilates equipment out there. I've got the Cadillac, the Reformer. Just trying to think anything else I could do on any of those while he's with me. Prone on the ball is great. I love that one. The backwards walking, I'm going to revisit. The all fours in different contexts is great.
Well, you can do the foot bar with him on the Pilates.
Yes.
You know, where
How
he's
can I
having
take
to, well, he would just do it with one foot.
Yeah.
You know, have him bend the other
it.
leg and put it with the one foot, and he has to control the movement of the platform.
Yeah.
But you could do it with the board on there, and you could do it with the bar on there.
The jump bar, the jump board, right.
So you could do it with the board, and then you could do it with the bar, but have him go into, that'll help him go into more dorsiflexion as well, because he can, you know, as he comes down, you know,
Yeah.
and he can't compensate. So he's not going to extend his knee as much because he can't compensate, but you can, you know, work on that, and where he, you know, he can feel his feet, you know, the balls of his feet on that bar, the foot bar.
Yeah.
Well, that could be some good things. And then he can do it with his heels.
Yeah.
Put his heels on the bar, and he can, you know, squat and extend, you know, in that position, and keeping his toes in you know, his toes pulled back. So he has to actively pull himself into dorsiflexion as he straightens out. That could be a backwards way of getting to it, but it could work really well. And it would, again, it'll be a different context.
Yes. What I'm also thinking of doing is getting him in an, like, one leg on the floor and one leg, like, let's say it's his right leg. So his right leg. So his right leg, his left leg's on the ground. He's kneeling on the plinth, on the Reformer, away from the headrest. So his foot is in dorsiflexion on one of the on the shoulder rest. So his foot's in dorsiflexion, and trying to see if he can fire his glutes in dorsiflexion and straighten his knee out as well. I think that now that I'm talking to you, I think I may try that as well. But for the listeners is, think about taking away their compensations. What can you do to take away their compensations for somebody like this? You know, so I love treating him. I enjoyed, you know, talking about him. I hope everybody enjoyed the part 1 and part 2. It may, you know, it's not an easy story to relate. So if anybody has any questions, don't hesitate to, you know, reach out. But the point is that he had 2 drivers. Initially, they made each other worse. Then he had a neural tension piece as well. And the exercise progression, you need to work with what he can do, and how you can tailor it to make it easier at the beginning for both regions of the body, and then at the end make it a bit more challenging for each region, and also take away the compensations. Because for somebody like him, I mean, you know, when you have 5 regions of the body, and so that bothered him. So ironically, he's like, you know, Erica, my neck pain's gone, my sternal stuff is gone. I'm like, of course it is, right? So just goes to show you that you need to really hone in on the drivers, and a lot of this other stuff will just clean up automatically, right?
Yep.
So
sounds great.
That. Awesome.
Thanks for sharing this case. Yeah, thanks for sharing this case. We'd love to hear from you. Leave us a review. Let us know how things are going, and we'll see you in a couple of weeks.
Sounds good. Bye.